All right, let's start our webinar. Hi everyone, welcome to our weekly webinar organized by the College of Physicians Malaysia. Theme of the month is Haematology, and we are very fortunate today to have Dr. Liu Hong Keng, Consultant Clinical Hematologist at Hospital Pulau Pinang, to be our chairperson. Without further ado, let us welcome Dr. Liu.
Good afternoon. Hi, thanks, Kevin, for the introduction. I'll start off the session. Firstly, I would like to thank everyone for taking this afternoon to join us on this weekly seminar, on this weekly webinar. Where this month we are focusing on hematological disorders. So let me introduce our speaker today. He's Dr. Ong Junji, or we usually call him Dr. Ong JJ. He graduated with an MBBS before going on to get his MRCP UK. He has worked at many places from Perlis Hospital Tuanku Fauzia, even worked in Sabah and Hospital Lahad Datu, and before coming back to Hospital Kuala Lumpur. After becoming a physician, he decided that he would like to do hematology and joined as a hematology trainee, first at Hospital Ampang, then a year stint in Hospital Pulau Pinang, before continuing and where he's currently attached to at Hospital Ampang. With that, I'd like to pass the microphone over to Dr. Ong, who will take you all on this broad topic of myelodysplastic syndromes. Dr. Ong?
Okay, thanks, Dr. Liu, for the very kind introduction, and thanks to the organizer for inviting me to share my knowledge, and also thanks to all the attendees for uh, for attending this webinar. So I'll be presenting myelodysplastic syndrome. I think it is kind of a very strange disease to many of you. So it's very kind of very sub-topic, but I'll try to make it simple. Although the management is very sub-specialized management, but I think to reach the diagnosis is very important. So yeah, okay. So let's start. Mm. So my presentation will cover the two case presentation, introduction about the disease, clinical presentation, diagnosis, management, and prognosis. So let's start with the first case. So we have a 71 years old lady with an underlying lumbar spondylosis, multinodular goiter, generalized anxiety disorder. So she initially noted to have leukopenia since 2016, where the full blood count show white cell of 2.2, hemoglobin and platelet rather normal. So since then, she has been monitored with the full blood count, where the white blood count ranging from 2 to 3, MCV and MCH within normal range. So some blood tests have been done to 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 try to look for the underlying cause. Iron studies, B12 and folate normal. Patient had normal kidney and also liver function. She has no frequent infection, never received any blood transfusion, and she has no significant physical finding clinically. So basically, just incidental finding of this leukopenia. So because the patient is rather asymptomatic and healthy, with no complaints, so the initial treating doctor has been just following up the patient with a full blood count. So then started to notice progressive worsening of anemia, where the full blood count in July 2023 showed the hemoglobin of 8.9. So white blood count still maintain around 2.2 plus like that. So the doctors decided to send a full blood picture in July 2023, which show a moderate anemia with poor rectic response. RBC appear to be normochromic rhomocytic. Then there's occasional elliptocytes and nucleated RBC, platelet adequate and unremarkable. So white blood count show reduced. White blood count is reduced with mild neutropenia, few hypolobated and pseudopelvic with cell seen, no blast or emergent cell. So please note that a lot of time when you have this kind of disease, this kind of patient, the full blood picture can be quite insignificant or unremarkable. So but somehow this full blood picture can show some dysplastic white blood cell where this presence of hypolobated and pseudophilic Kuwait cells are some features of myelodysplastic disease. Anyway, so just move on. So the treating doctor decided to perform a marrow examination, which shows the marrow aspirate shows hypercellular for her age, is relatively increased in the erythropoiesis with normal blasting maturation. There's mild this erythropoiesis such as nuclear budding, intercycloplasmic bridging. So later I will show all the some picture of the all these feature under a microscope. So there also make some megaloblastic changes. In terms of myelopoiesis, is relatively reduced with life shift. There's dysplastic feature such as hyposegmentation, pseudopelchal, and also hypogranulation. Megakaryocyte appear increased with also some dysplastic changes such as hyperlobulated and abnormal nuclear shape, occasional macromegakaryocyte. Some megakaryocyte are hypolobated with a separated nuclei. Then we also check the iron stain on the bone marrow aspirate, which show ring sideroblasts more than 15% of the total erythroid. So the impression from the marrow examination shows that these morphology features are suggestive of myelodysplastic syndrome with low blast. Fine shows that all three hematopoietic cell lineages are present. Erythropoiesis is increased, MPL positive granulopoiesis appear reduced with life shift maturation, and also megakaryopoiesis appear mildly increased. Also, it shows some dysplastic changes as mentioned in the marrow aspirate. Then during the marrow examination, we also sense cytogenetic, which show trisomy 19 with deletion 16q. Serum erythropoietin also sent, which show a level of 9 milli IU per mil. So the diagnosis is myelodysplastic low blast. So the treatment was given initially was danazol. Danazol is a kind of androgen, my synthetic androgen. Okay, it has been shown to be in some cases to be able to stimulate erythropoiesis. So pyridoxine 10 milligram OD. Yeah, this also have also in some cases has been shown to stimulate erythropoiesis. So folic acid and Iprex 4,000 unit 2 times a week. So when we see this serum EPO of 9, so in general, whenever the serum EPO is less than 200 milli IU per mil in the case of MDS, usually we can try erythropoietin where it probably can show some response. So last review in May 2025, the patient remained well with a rather stable count with a white blood count of 2.1, hemoglobin 9.2, platelet of 283. So just a recap. It's an elderly. So she started having some leukopenia in 2016, and now 9 years down the road, she still remain well. So okay, let's see the next case. Oh yeah, before that, sorry. So what do you think her prognosis is? I think I've already told you all, it's already 10 years. So how long she can live? What's the chance of her getting AML? So these are important questions when we come to prognosis. So how do we prognosticate the patient? So there's a prognosis score we call as MDS MDS IPSSR. So where after I put in the value here, so usually the criteria the question that you ask for this questionnaire is the age, the blast count in the bone marrow, the karyotype, whether is it a low risk, intermediate risk, or high risk or adverse risk karyotype. Karyotype means cytogenetic. Hemoglobin level, the ANC count, platelets count. So the score of the patient, MDS IPSSR score of the patient is 2. So she's under the low risk MDS group. So median survival is 5.3 years. So in this subgroup of patients, so they also give you uh, uh, the risk of progression to AML, which is by 10.8 years. So probably, so now it's already 9 years plus, close approaching 10 years. So probably you expect a patient may be having AML in the next maybe 2 3 years like that. But this is just an estimation. So probably some of the patient may not develop AML until they die also. So it's okay. Let's see the next case. So just now it's an elderly. So now it's rather a young patient, 47 years old man. He presented in February 2024 with pancytopenia. So you can see the white blood count of wait I got white blood as such, hemoglobin of, hold on, I can't really see here. White blood count of 6.2, hemoglobin is 7.8, platelet of 15, ANC 3.8, MCV and MCH normal. He denies taking any medication or supplements. There's no significant physical finding besides parallel. Kidney function, liver function, again, is normal. Iron studies, beta folate, normal. So we have performed a marrow examination for the patient, where the SPH show, again, slightly hypercellular. Erythropoiesis is slightly increased with megaloblastosis, some with binucleated forms and choriorexic seen. So these are all the dysplastic feature. Granulopoiesis is normal with some dysplastic neutrophils and no increase in blast. Megakaryopoiesis is reduced. Iron stain increase, ring sideroblasts absent. So impression is findings are suggestive of MDS. So bear in mind that the counts of this patient compared to our previous patient is actually way more severe that can cause symptom. So trephine show erythropoiesis is increased, granulopoiesis is normal with no increase in bloods. Megakaryopoiesis is normal with dysplastic megakaryocyte seen. Cytogenetic shows a deletion of 13q. Next generation sequencing NGS AML panel shows no significant variant detected. So bear in mind that next generation sequencing NGS is actually um, uh, considered an essential workup for MDS. So where it is very important to guide treatment and also prognosis. So I will explain further later. But so also bear in mind that this patient only has NGS AML panel. So by right, he should have an NGS MDS panel which cover more molecular genetic study. But anyway, so let's move on. So what's his prognosis and how long he can live? So again, the same question we will ask. So prognosis, the mortality, chance of the patient, the disease progressing into AML. So the age is 47 years old. The blast count is still okay, 0 to 2%. Karyotype is intermediate risk. Hemoglobin is less than 80 gram per liter. NC is still good. Platelet is low. So the total up all the score, the patients have a 3.9 of score. His group under intermediate risk. So just now the elderly was low risk. So this patient is intermediate risk. And you can see that the median survival for this risk group is 3 years. So he is 47 years old. If a median survival of 3 years, it is considered quite short for him. Then there's also 25% of them will undergo evolution to acute myeloid leukemia by 3.2 years. So it's in the young patient, these are all very significant for him. So because of his prognosis and the disease pattern, he was planned his management plan will be to give some chemotherapy. So the treating doctor used hypomethylating agents, follow uh, followed by allogenic stem cell transplant. This is the plan, long-term plan initially. So he was given the first cycle of hypomethylating agent with a subcutaneous azacitidine for 7 days. Unfortunately, from the first cycle of chemo, he developed complication where he had neutropenic septic shock, which ended up with multi-organ failure, and he succumbed. So to start with, I was introduce what is MDS. So it's a clonal disorder of hematopoietic stem cell characterized by bone marrow failure associated with dysplastic cell morphology in one or more cell lineage. There's a simultaneous proliferation and apoptosis of hematopoietic cells, which means there's ineffective hematopoiesis. Paradox of hypercellular bone marrow, but pancytopenia in peripheral blood. So in the marrow, you will see a lot of cells, but in the blood, in the peripheral blood, the patient will have reduced count. Is either anemia or thrombocytopenia or leukopenia. So this is because of the ineffective hematopoiesis, where once the cells being produced, their lifespan is very short because of the dysplastic feature, or they are already destroyed before going into the peripheral blood. So they are destroyed in the bone marrow before they go into the peripheral blood. So there's increased risk of acute myeloid leukemia. Incidence is actually not many, about 1 in 100,000 per year. Predominantly male, and the median age is 70 years old. It's kind of a disease of elderly. Only about 10% are younger than 50 years old. So what are the possible etiology? So exposure to ionizing radiation. So it's very important for us to try to look for the underlying cause, and also from the history. A detailed history is very important for you to when we all encounter a person with a patient who come with a cytopenia, whether is it white cell, red cell, or platelet. So you have to try to find out the cause. Sometimes it may not be myelodysplastic syndrome. So it can be a lot of causes. So it can be drug induced, it can be infection induced, it can be an exposure to radiation before. For example, people who have some form of cancer who receive radiotherapy, lymphoma, who has radiotherapy, or breast cancer, whatever disease which they receive radiotherapy. Let's say they are working in an area with exposure to a lot of radiation, then smoking history, then occupation. Sometimes the occupation may have a chemical hazard, then prolonged exposure to low dose chemotherapy for controlling some autoimmune disorder, for example, SLE. So long term usage of methotrexate, things like methotrexate, azathioprine. Sometimes it can be a risk of developing myelodysplastic syndrome, or it can even be the drug itself causing the cytopenia. Usually, the clinical presentation will depends on how bad is how depends on the cytopenia. So the patient may have anemic symptom, then sometimes requiring transfusion, frequent infection because of the neutropenia or defective neutrophils, easy bruising or bleeding because of the low platelet. So they can also be asymptomatic when it is detected early, and come with just slightly abnormal blood count during a routine medical checkup, or during an admission for an unrelated condition. So WHO diagnosis of MDS require the following. So the first one or more persistent cytopenias not attributable to medication or nutritional deficiency or other medical condition. Morphological dysplasia more than 10% in more than one lineage. In one or more lineage, actually one lineage also can be considered. If let's say in one lineage, you can find there's more than 10% of morphological dysplasia is also one of the criteria. So increased myeloblasts, uh, more than 5% in marrow, 2% in periphery, but less than 20%. So if more than 20%, this is no longer an MDS, it can be considered acute leukemia already. So evidence of clonality with typical MDS-associated cytogenetic abnormalities. So the latest fifth edition divide the diagnosis into two groups. So the first group is MDS with a defining genetic abnormalities, where there's a typical genetic abnormalities that we know which can commonly cause myelodysplastic syndrome. Another one is by morphologically defined. So by looking in your bone marrow SPA and also the trephine for the dysplastic feature of the blood cells. Sometimes this myelodysplastic syndrome, the morphology can be quite challenging. Uh, so it's sometimes it can be not so easy lah. Because you can see that the dysplastic feature itself sometimes it can be subjective. Some hematopathologists will think, okay, this is dysplastic. Some may think that it's considered quite normal. Then when you look at the percentage of count, so sometimes the percentage of the blast also may be subjective. So it really poses some challenge in the diagnosis sometimes. So and also that there's detection of more than 15% ring sideroblast may substitute for SF3B1 mutation, which is NDS with low blast and ring sideroblast. So this is actually a distinct kind of MDS where there's a specific treatment for it. I mean, different from other form of MDS. Then recognition of hypoplastic MDS as a distinct disease type, another distinct disease type associated with T-cell mediated immune attack on hematopoietic stem cell, features overlapping between aplastic anemia and PNH. So just now I mentioned that most of the myelodysplastic syndrome will have a hypercellular marrow, but peripheral blood cytopenia. But we have a distinct type of MDS. We call it hypoplastic MDS, where there's hypoplastic marrow together with peripheral blood cytopenia. This type of MDS, they always overlap with between aplastic anemia and paroxysmal nocturnal hemoglobinuria. So this kind of hypoplastic MDS, they are usually associated with T cell immune attack. So the treatment, sometimes you can try on some immunosuppressive strategy. So the diagnosis is initial investigation to so will standard will be full blood count, full blood picture, beta folate ferritin to rule out other causes of cytopenia, renal function, liver function, Coombs test to see whether there's any hemolysis, for example, A1 syndrome. Okay. Then bone marrow examination. MDS is basically a diagnosis of diagnosis that require marrow examination. We cannot diagnose MDS without marrow examination. So we have to assess the morphology. Then we have to do iron stain of the SPA because, as I said just now, there's a distinct form of MDS with a ring sideroblast, so which may have its unique treatment. The cellularity assessment and reticulin strain. So we want to know whether it's a hypercellular or hypocellular. Cytogenetic analysis is very important. So I would like to also emphasize this cytogenetic analysis. So a lot of time I find that from non-hemato center, for example, the other center, so the other tertiary center. So many of the general medical doctors, they are able to identify possibility of MDS, and they proceed for marrow examination. But um, a lot of time, it's kind of I say frustrating that when we cannot get a very good bone marrow aspiration sample, and also the bone marrow aspiration sample for morphology review, as well as the cytogenetic analysis. So probably my advice will be, whenever uh, you all do the bone marrow examination, bone marrow aspiration and trophine, so try to get, I mean, I welcome junior to do, but at the same time, if, a senior should be available to help. If let's say a junior doctor is unable to get a very good aspirate with a good fragment, then the probably the senior person can help with that, because cytogenetic is a very important part of the marrow the diagnosis. Then immunophenotyping with analysis of apparent antigen expression and quantification of marrow blast. So immunophenotyping, in other words, is flow cytometry. So this sometimes can be useful, especially in quantification of blast, where we suspect probably this patient has increased blast or low blast, or actually is acute leukemia. So they can help us to kind of assess the to quantify the blast. And then another thing is a next generation sequencing, NGS. So this next generation sequencing um, is also very important, but it's not widely available in our country yet. So which means, okay, we can actually send this NGS to certain places, for example, IMR. Ampang also starting to offer this test, but only to our own patient. Uh, I mean, due to the, we are just starting to offer this test, and it's actually confined to acute myeloid leukemia, not yet expanding to MDS. I believe IMR is also offering NGS for AML so far, but I believe that the service will expand further in the future to cover myelodysplastic syndrome panel. So okay, so from peripheral blood, red blood cell, you can see anisocytosis or poikilocytosis. Anisocytosis means different size, different size of red cell. Poikilocytosis cytosis means different shape, so different shape, different size. Sometimes you can find macrocytic and oval-shaped red blood cell. In sideroblastic anemia, there's a dimorphic picture with small population of hypochromic microcytic cells, basophilic stippling, Pappenheimer bodies, white cell count, white blood cell, neutropenia, hypogranular neutrophils, pseudoPelher. These are the maximum finding you can get from the peripheral blood. But I can tell you, probably more than half of the time you won't find any significant finding from peripheral blood picture of a patient with MDS. Then in marrow, yeah, marrow will give you very informative uh, informative point uh, to your diagnosis. So in terms of cellularity, in terms of the dysplastic feature of the erythroid, the granulopoiesis, and there's also megakaryopoiesis. So in terms of this erythropoiesis, so you can see from peripheral blood. So these are all the oval macrocytes. Oval macrocytes. So and dimorphic RBC population. So sometimes you can see um, uh, rather microcytic hypochromic, sometimes hyperchromic. Then poikilocytes, you can see some target cells, some acanthocytes. Acanthocytes mean there are some projection, irregular projection on the surface. Elliptocytes, like pencil cell. So you can see from the bone marrow, you can see sometimes see erythroid hyperplasia, megaloblastoid changes. So multiple nucleus. So by right, erythroid should have only one nucleus, but this one has multiple nucleus. Karyorrhexis, so means the nucleus is not very mature and large. Then cytoplasmic fraying and blabbing, you can see around the cytoplasmic, there are a lot of blabs. Then cytoplasmic bridging, you can see there's a thin line between the two erythroid cells. Then nuclear cytoplasmic dysynchrony means the nuclear is way more mature than the cytoplasm. Then other findings are nuclear budding, ring sideroblast. So I show you what is ring sideroblast later. So this granulopoiesis, so these are all the white cell. So from the peripheral blood, you can probably see pseudopelvic where these only two lobes, and then usually the neutrophil have 3 to 5 lobes, 3 to 5 segments. So sometimes you can have abnormal segmentation, hyper-segmented neutrophil, abnormal nuclear shape, and then the cytoplasm can be hypogranular, so not much of granules around. Then from bone marrow, you can sometimes see uneven cytoplasmic staining and granules, abnormal myelocytes with basophilic staining. And then when you see myeloblast, so you have also have to quantify the percentage of myeloblast to know whether the patient belongs to MDS with low blast, MDS with increased blast, or MDS with transforming to acute myeloid leukemia. In terms of this megakaryopoiesis, so the megakaryocytes, sometimes you can see they are monolobular nucleus, separated nuclei, and micromegakaryocyte, which are small megakaryocyte. Then the picture showing the ring sideroblast. So all this the blue color one is the iron deposits around the red cells. It is actually ineffective formation of the heme from the using the iron. So flow cytometry or we call, is the same thing as immunophenotyping. So it can be useful in the enumeration of the blast count, but a lot of time if it's just MDS, it shows no specific immunophenotyping. So basically, flow cytometry cannot help you to diagnose MDS, but it can help you to ascertain whether this patient has um, the disease has already is in a low blast category or increased blast category, or is actually more favoring acute myeloid leukemia. So cytogenetic, yeah, these are the prognosis subgroup. So as I mentioned just now, cytogenetic is very important to help us, to guide us, to help us in prognosticate the patient. At the same time, some of the cytogenetic information can guide us with the treatment. Okay. So, this is another thing that I mentioned just now, the next generation sequencing. So this NGS detects somatic mutation. So when you have this information, it will also help you with the prognosis. So just now I mentioned the what's it called, the MDS IPSSR prognosis score, but actually there's a newer prognosis score called MDS IPSSM. So where in some country where the new next generation sequencing is widely available, they actually move on to use this MDS IPSSR to prognosticate the patient. So but since our country is in our country, the next generation sequencing is still not widely available, so we generally still using my MDS IPSSR prognosis score. But this molecular genetics can actually be very helpful in guiding us with the treatment when we know what kind of the somatic mutation is present. Further investigation, so sometimes we may want to send erythropoietin to see if low level, then we know probably we can use erythropoietin to treatment. Then flow cytometric screen for paroxysmal nocturnal hemoglobinuria when you encounter a case of hypoplastic MDS. Fanconi anemia screening, mutational analysis, and infective screening. Sometimes you may not know. Sometimes HIV, the cytopenia is because of the virus, like such as HIV. Then sometimes you may also want to send JAK2 when you suspect a component of myeloproliferation. Okay, and the other things, red blood cell phenotyping, if the patient requiring frequent transfusion, frequent long-term transfusion, uh, just like thalassemia patient, when they need a chronic frequent transfusion, then preferably to have a red blood cell phenotyping so that you know the baseline antibody of the patient. So this is the, okay, I have already talked about this IPSS-R prognostic score value just now. So which includes cytogenetic, bone marrow blast percentage, hemoglobin level, platelets level, and ANC count. So the higher the score, the poorer the prognosis. Okay. So so yeah, the rapid development of this NGS has led to better understanding. Yeah, that's why. So some of, yeah, I actually talked about this before. IPSSM. So yeah, it's very good if we can have this NGS to detect the molecular genetic abnormality of the patient. So MDS is actually a very heterogeneous disease. What it means is, uh, it's not like it's not like let's say let's say what uh, okay hypertension. Then your treatment is antihypertensive. Okay, so so this one this MDS it depends on the prognosis. It depends on the cytogenetic and molecular genetic information, the comorbidity of the patient, age of the patient preference, and your therapeutic goals. So what is your goal of treatment? This is very important because we don't treat the disease, we treat the patient. So like in the first patient that I presented just now, the elderly with initial presentation is the leukopenia. So the patient is rather asymptomatic with leukopenia. So you usually we'll just monitor, and we know that her disease is low risk. So mainly we monitor, and then when there we monitor basically for the worsening of cytopenia and also development of acute myeloid leukemia later. If not necessary, actually some of them do need treatment, or some of them may only need uh, some treatment, for example, erythropoietin, um, uh, this hormonal supplement, or some other treatment which is not so intensive, like chemotherapy. Also, supportive care also play a very important role, uh, because we have to know that MDS usually happen, majority of the patient with MDS is elderly. So a lot of time they are not very fit for the appropriate treatment. So um, many a time we actually can only offer transfusion, supportive transfusion, and some oral treatment, for example, like if the patient come with low platelet, intermittent bleeding, kind of bleeding, then probably you can give platelet transfusion and also tranexamic acid. So and then if the patient has leukopenia with frequent infection, then we can give some antimicrobial therapy. It all depends on the how bad, how severe is the cytopenia, what's the patient presentation, and the comorbidities, as I mentioned just now, the age comorbidities, the 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 disease biology, the disease characteristic. So hematopoietic growth factors, for example, recombinant erythropoietin, such as Epres recombinant, it is useful in the treatment of anemia, especially if the serum EPO is less than 200. So bear in mind that the dose of the erythropoietin in MDS treatment is very high. So you can, I believe that your if you all have already have gone through nephroposting, a lot of end-stage renal failure will receive erythropoietin. So the dose is usually just like 4,000 unit 2 times a week or 3 times a week. We rarely use more than 10,000, but in MDS, actually the dose requirement is very high. So it can go up to 30,000 IU. So initially you give for 8 weeks. So if there's no improvement at all, you actually can push up the dose to 60,000 unit. And then so you don't try forever. Basically, you start this patient on erythropoietin. You have to monitor whether there's any improvement after even after titrating up the dose. So if there's no improvement, then you don't continue after say like after 6 months, because you know that it's not going to work. Then granulocyte colony stimulating factor GCSF. So we don't we don't give GCSF to all leukopenia or neutropenia patients. So it all depends. When if the patient come in with a severe sepsis or recurring from intensive chemotherapy, then yes, probably the GCSF may be useful. But if the patient is asymptomatic, not much of issue, there's actually no need to no benefit of using GCSF for this group of patient. And sometimes GCSF can be combined with erythropoietin in those patients with refractory anemia with ring sideroblast. So this MDS with refractory anemia with ring sideroblast. So if let's say the erythropoietin level is low, you try erythropoietin already, not much of improvement. Actually, you can add GCSF to enhance the response. So immunosuppression, just now I talked about a distinct type of MDS, which is a hypoplastic MDS. So the main pathophysiology is immune related. So you can use some immunosuppression with ADG and cyclosporine, treat something like severe aplastic anemia. So severe aplastic anemia is also another immune mediated disease, especially T cell mediated. So usually you will use immunosuppressive therapy like anti-thymocyte globulin combined with cyclosporine for the treatment. Chelation therapy. So when you have a patient with requiring prolonged long-term frequent transfusion, then you may want to offer them chelation therapy. But you only offer this chelation therapy to those patients with a good prognosis that you expect the patient will live very long, will have many more years to go. So then if you continue to give supportive blood transfusion, PEG cell transfusion, then the patient will end up with iron overload. Then you can offer this chelation therapy. Otherwise, as I said, patients with MDS majority are elderly, so their survival may be not too long. So giving chelation therapy may not be that useful, because you may just increase the burden of those iron chelation infusion, or when the benefit is actually not much. So any of the three main iron chelator can be used, but you have to to be careful in to use deferriprone in patient with leukopenia because it can cause neutropenia. So MDS can only be cured by allogeneic stem cell transplant, which means we use other people's stem cell to transplant into the patient's marrow. So it's called allogeneic stem cell transplant. So sometimes we may give patient intensive chemotherapy so followed by allogeneic stem cell transplant if our therapeutic aim is to cure. Usually this reserved for younger patient, younger and fit patient with not much of comorbidities. So yeah, this allogeneic stem cell transplant is the only way to cure the disease. But we also have to understand that uh, performing allogeneic stem cell transplant in patients with MDS sometimes may not be very easy, may not be very successful. So hypomethylating drugs sometimes can improve the blood count. So the two hypomethylating drugs that we commonly use are azacitidine or dacitabine. Lenalidomide. Okay, this so probably some of you may heard of lenalidomide if you go through hematoposting. It is a very common it's a drug that commonly used for multiple myeloma, but it's also found to be effective in certain type of MDS, especially for those with deletion 5q. So as I mentioned just now, if you know the cytogenetic uh, information about the disease, then you can you know what kind of treatment probably can offer a positive result. The Luspatercept, yeah, this indicator for low risk MDS. So specifically for ring refractory anemia, ring sideroblast type. Okay. So now we also besides the MDS, so some MDS may not be purely MDS. They may be an overlap of MDS. So examples are CMML, MDS, myeloproliferative neoplasm with neutrophilia, myelodysplastic, myeloproliferative neoplasm with SSP, and so on. But probably just for you to have an idea about this, but not too much of detail into it. So these are the CMML diagnostic criteria according to the WHO 2022 classification. So you can see here that MDS can come with low count, of less than 30, but some of them can be with a high count. It can be up to 20, 30 plus, where there are myeloproliferative CMML. So CMML itself is a dysplastic disease, but it can overlap with myeloproliferation. Again, CMML can also majority of the CMML patient are elderly, and they can have two categories, and they may have the potential to turn into acute myeloid leukemia. So these are CMML prognosis scoring system. It has its own scoring system for prognosis. CMML treatment overview, majority, as I said, elderly. So the clinical course ranges from indolent to aggressive. So some people may have very um, short-term survival. Some can actually live very long. It depends on the aggressiveness of the disease. So sometimes you may need to follow up the patient for a period of time to see the progression. So it's not very easy sometimes to risk stratify the patient. So it all depends on the rate of worsening, the rate of progression of the disease by the count monitoring. So besides supportive chemotherapy, yeah, so if you have a myeloproliferative kind of MDS, CMML, where the white cell is high, then probably you can use hydroxyurea oral therapy. Then in younger patients and fit patient, probably you will consider offering allogeneic stem cell transplant, especially if they have met sibling donor. Hypomethylating agents sometimes may be used, although the efficacy is not um, very promising, but sometimes it may reverse the cytopenia in certain patients, reducing spleen size and improve symptom. Yeah, I think that's all for my presentation. These are the references.
Right. Thank you, Dr. Ong, for bringing us on this broad topic of myelodysplastic syndrome. Now we'll open the floor to questions. I can see there are some questions, but maybe I can start with some question of my own first. You mentioned about MDS with the 5Q minus syndrome, which you touch on when you talk about management. But it's a very unique entity. And do you want to tell the participants or the audience, what do you know? What's the typical findings if a patient to come to this presents with what we suspect to be a MDS with a 5Q minus?
Mm, mm. Sorry, don't really touch on it.
Yeah. Do you want to highlight the typical features that you normally find? Because normally these patients, isn't it? They will normally come with anemia. They can have normal, slightly low white count, and they can have low or even, sorry, they have normal or high platelets.
Mm-hmm.
So they come with refractory anemia, and they can
Or
have
the
normal or low white
macrocytosis.
count, and they can have a thrombocytosis. Okay, because when people see thrombocytosis, they do not think about MDS.
Mm-hmm.
And the anemia is typically macrocytic.
Oh,
It's
okay.
one of the, isn't it? It's one of the low risk MDS.
Yes.
And for this reason, I think the WHO and the ICC new classification, besides looking at this PCR, the first step is your cytogenetics. And of
yes.
course, if you can, the NGS for the MDS panel, which unfortunately here you still need to send to a private lab. So you did mention that lenalidomide. There are two ways of dosing it for 5Q minus. One is a dose is at 10 milligrams. It's dose like myeloma, day 128. Or you can even do a continuous dosing as per the NEJM publication.
Okay.
Okay, maybe let's go to the online question. Somebody asked, the NGS panel from your case, is it from serum or marrow sample?
Oh, yeah. Okay.
Definitely answer is
NGS.
not serum lah, because serum will not have cells lah.
Yeah.
I think what they meant is it from a peripheral blood or marrow sample? Yeah. So what was the scenario in your patient?
Oh, actually, NGS can be sent using serum.
Not serum,
I mean,
peripheral blood.
peripheral blood. Peripheral blood. So yeah. So not necessarily from marrow sample actually. Yeah.
So I think if you look at available guidance, is that of course the gold standard is marrow, but there's very good concordance with peripheral blood, isn't it? So
Yes.
you don't necessarily have to take marrow. Of course, that will be the ideal if you're already doing a bone marrow.
Yeah.
The next question is someone asked, how do we approach an old patient with MDS features from the full blood picture, but then refuse bone marrow? And it went on to ask, when should we decide palliative care for this kind of patient? You want to try and answer that?
Okay. Yeah. So okay. It all depends on it depends on a lot of factors. So basically, we want to know, okay, the patient, as I said, we cannot diagnose a patient with MDS from peripheral blood, full blood, for example, full blood picture finding. So then if we cannot diagnose, then okay, we cannot label this MDS. So then, if the patient refused the marrow examination and we don't really know what's the real disease, then we will depends on how's the patient presentation. Does the patient present to you with recurrent infection, with anemia, or with this thrombocytopenia, bleeding, for example, bleeding? A lot of time is supportive transfusion. They can probably some old patient with MDS feature. Okay, they are not too bad. They are just probably the mildly leukopenia, maybe the white cells one between 1 to 2, hemoglobin about 8 to 9, platelet maybe about 30 to 40, but they are actually quite okay. So they just admitted for probably some infection, then go home. And you probably just need to monitor them. You don't even need to. Uh, of course, if you want to know the diagnosis, then you have to do marrow. But if they don't want and they are still okay, probably you can just monitor them. And when the disease progress and they still refuse for marrow examination for a certain diagnosis, then you can actually sometimes give supportive transfusion. Another way is if they don't want to do invasive procedure, if they want to know whether we can have some idea like you can actually send peripheral blood for NGS to know whether the patient has some molecular abnormal molecular genetics to kind of like um see whether the patient may have what kind of MDS. Yeah. Then
Yeah.
palliative care. Okay, if let's say a patient MDS come with you very very severe cytopenia, then they always come in with recurrent infection because severe sepsis because of severe neutropenia, leukopenia, and the patient refuses for bone marrow examination. Probably this kind of patient, you know that they come in every time in very severe sepsis, bad shape. Then you can probably introduce palliative care for this kind of patient. Then
I think ultimately
bear
it's
in
a
mind that
discussion. Yeah,
mm,
ultimately it's a discussion with the patient.
yeah, correct.
As you rightly say, isn't it? If the patient is just some degree of cytopenias, but doing along well, where the treatment is basically supportive, and because you never have the marrow as a diagnosis, you never cannot 100% confirm. So basically, if
Mm,
they're doing along well, yes, I agree that you can just offer supportive care, as you
mm,
said, supportive transfusions. But if the patient is really elderly, as you say, old patient, and is coming with a lot of complications already, even if you do find more features that suggest that you need to give further therapy or prevent delay progression to AML, you also need to have a long talk with the patient whether he or she can actually tolerate or not. But yeah, you are absolutely right. Then the bone marrow would be required to actually confirm the diagnosis. The NGS sounds promising from the blood. Just that you can have those abnormalities even in someone without actual diagnosis of MDS, but it does point you in that direction. But again,
mm,
whether they are willing to do that or not.
mm.
Okay, looks like. Do we have any other questions? So we don't have any other questions. Maybe another way I can ask is you mentioned about the classification, right? Did you have a slide that you want to show off the newer classification?
Okay.
Because I think the classification currently just looks at both genetics and molecular, but it doesn't really tell you, patients low risk or high risk, which you then have to fall back to the IPSS, isn't it?
Yeah, correct. Yeah, this is the one.
Yeah, correct.
Mm.
So I think to highlight that because it relies on if you look at the genetic anomalies, the SF3B1, the biallelic DP53 is something that, here we don't offer as a routine unless patient sends to a private center.
Yeah.
Yep. Okay, looks like we don't have any more questions. And with that, I think we are almost out of time as well. Like to thank everyone for joining us today. And thank you, Dr. Ong, for taking us through this topic.
Thank you, Dr. Liu. Thank you, Dr. Calvin, and thanks to everyone.
Thanks, Dr. Liu, for chairing the session and Dr. Ong for the wonderful talk. We'll see you again next week.
Right. Bye-bye.
Bye-bye.
Thank you, everyone. See you next week.